Good morning, everyone. Today, as every year, is the week after the American College of Surgeons, and we are extremely honored and pleased to have one of the recipients of the International Scholarship of the American College of Surgeons. Dr. Araujo is a surgical oncologist specialized in HPV surgery. He completed his training in surgical oncology at Camargo Cancer Center in São Paulo. He then spent 2 years Memorial Sloan Kettering for a research fellowship, and after that, actually spent 1 year in Paris in the very famous Paul Brousse Hospital to complete a clinical fellowship in HPV. He then later completed his PhD in 2015 and postdoc in gastroenterology in 2017 at University of São Paulo. From 2015 to 2018, he was chief of the Department of Upper GI and HPV Surgery at Barretos Cancer Hospital. He's the former scientific director of the Brazilian Society of Surgical Oncology and currently is adjunct professor of surgery at the Escola Paulista de Medicina in São Paulo. Today is here to talk about a very intriguing topic, which is the patient selection for surgical treatment of colorectal liver metastases. Raphael, welcome.
Good morning, everyone. So thank you for hosting me. I'm so proud and happy to be here. I told Professor that it's one of my biggest honor to be here. In my modest career, I really happy to be here. So I will start to discuss a little. I had done about patient selection for resectable colorectal liver metastases. This is, I don't have, sorry. Okay, now it's better. Okay, so I don't have any conflict for this. And what I'm thinking that as an introduction, we have to think also about the colorectal disease. It's impressive that it doesn't really matter how much progress we are achieving, but the numbers are impressive. They are increasing the last 30 years. We see that just deaths, we're not even talk about prevalence or incidence, but death, it's increasing for them. And for sure, when we look for the worldwide distribution, we see that the quite related also of development and income disparities. So that's interesting to think about that both for both incidence, but also related to mortality mainly. The disparities are really important. But looking for America, what we think that's nice to highlight that remains at third position of most common for both incidence and estimated death. And then here I have to show you that we are thinking about the patient selection for surgery for this kind of patient, we have like many different scenarios. Because could be simple if you have like a really standard case, really the initial case that you can prepare for to do just, one single indication, localized disease. You can have really advanced disease when you have many, many options and how to deal with that. So Anna, for example, has a lot of experience with pump and also medical oncologists with really advanced disease. So you have many, many ways to decide and to do. And honestly, it's really hard to think on how to adjust that. But today, what I'm thinking is something in the between, maybe like amateur radio, like this, that you have like to adjust to do and to organize your the pathway and experience of your patient. So the idea of this presentation is we keep it in colorectal liver metastasis, but just a resectable. Why just a resectable? Because this is the moment that we have to decide if you go to surgery, if you go to the chemotherapy, or think in something differently. Okay, and when I think about that, the first thing that came on why we should do it in the beginning, we are talking about when you look in the perspective, the historical perspective, we think that was the most important question: why we're doing surgery for metastatic disease, and in who, how, and when. So I always like to show this slide, and even it's for 80s. What's interesting that at that time in this series, we see that if you provide resection for patients, you could achieve almost more than 20% of in 5 years 5-year survival. And then when you looked for more recently, like a huge amount of patients, like more than 1,300 patients here, we see that goal that was our close to 20, now it's 40, and the 25 becomes 10 years. So a lot of progress on that. And this paper, it's interesting. It's a paper from Memorial that's showing that if you look just for disease-specific survival, it's an outcome that's hard to get it. Exactly, you need really good follow-up to be sure that you are talking about the disease-specific survival. And then they have like also getting better over years. So the secret, there is no secret other than patient selection. That's my point of view. And here, I don't have a lot of answers. I would say that, like Voltaire used to say, don't judge the people by their answers, but by their questions. So the questions, I can give you a lot of them, but the answers not that much. But when we're thinking about the patient selection, we have it so what we have like granted that we have a follow-up, an outcome that let's say around 30 to 60% of 5-year survival, but how to select them? So when you look again for the historical perspective, we're always thinking about clinical risk scores, and some of them appeared like those are the main of them. And the one that I use more, and I think that that's more common, especially in US, it's also the FONG score, and makes a lot of sense to me because they got a lot of validation in many other series. Why it's important and why it's first of all, when you look for this slide, the first field to attention, it's what's written upper there. But what I'd like to show you that this paper showed up in 1999. So at that time, we are basically using one drug. If those patients received drug for treat metastatic disease, was just one drug, not even the double or triplet chemotherapy as we have today. So that this is important because they selected which one of this variable got 1 point. That's interesting because this is the way that they constructed this clinical risk score that you know well. And what's interesting that when you start to look at for that with low risk and high risk, it makes a lot of sense to split that way because you can understand even if the presentation regarding the image, they are pretty much the same patient for the same technical approach, perhaps how they were selected for them, the behavior will be totally different. But coming back to this point, this clinical risk score as an example, so the median survival was 4 months for 0. This is great. At that time, 99. And then really worse for when you got off them. And again, this paper, it was a series that published in 2018 from Memorial Sloan Kettering as well. And they split the disease-specific survival, and you can realize that the difference is really big among low and high risk. So how the patient selection must be based on, I always have this conversation with my residents and fellows, because when you start, and it's especially in my country that sometimes that's not only the surgery, but the environment where we are performing surgery makes a lot of difference. So sometimes we do the patient selection, but we never ever can forget about clinical performance of this patient, because it will be the difference if you're providing like a curative or palliative intent treatment. What I'm trying to say that the surgery cannot be worse than the cancer itself. So those patients, we cannot forget that the cardiovascular diseases and many others are important player on those patients, especially if you talk about elderly patients. So this is really important. So the first things first, I guess it's the most important thing. And then when we move and come back to, come back to presentation, resectable or unresectable. You know, a lot of debate in the literature, what's resectable, it's not resectable. For example, last Friday, I was here to see a surgery of a patient at my concept and all my life concept, what would be unresectable. And Professor Delgado was really motivated. It's just, just a normal Friday, let's do it. If you are lucky, we got the happy hour later. So that's, like, it depends where you are, the experience. So it's a long debate and how to do it and when. So this is really hard to address, but we come back to that point later when you talk a little bit more about surgery. And then extrahepatic disease. Extrahepatic disease, it's also complicated, but the most important thing in my mind is realize that when we are talking about extrahepatic disease, we are not talking always as separated issue. There is many degrees of extrahepatic disease and how they influence. So definitely they made a drawback of the expectations for overall survival and recurrence-free survival. But definitely, when you look more close, we realize that some of them had really good results that make sense for me, at least, to invest in those patients. However, when you have like patients with portal or retroperitoneal disease, usually they are doing badly, regardless if are performing surgery or not. So that's really complicated, but you have to pay attention about that. And about the tumor location, well, tumor location, it's important to have to thinking about that, because if you talk about colon, it's one way to go. If you talk about rectum, it's totally different. And then the symptoms also, if you are talking about synchronous disease, it's much more complicated. And what this paper was a paper from Memorial. It's interesting because in that paper we checked that over years, the trends, and they start to do a lot of simultaneous resections over there. Not only staged resections for simultaneous resections. It's something that changed over years. And today, this paper is quite old, but today they just do simultaneous resection. That's interesting. And when we compare it to MD Anderson, this paper just show up. You see the trend that they also do reverse and combine more than the classic approach. Now, so the reverse will be the liver first, and combine together, and classic will be colon, and then later and second time liver. What's interesting that when you start to look the oncological outcomes from them, no difference regardless if we're doing when this staged or not for both overall survival and recurrence-free survival. And then with the MD Anderson series also, again, as the original paper from them for a couple of years ago, and this now, so no difference. So what make you decide? In my mind, what I'm going firstly for those organ or system that I'm more risk. For example, if I have a risk for obstruction or, a complex pelvic resection, perhaps it will be better to start that way. If I have like the liver, that if you have some minimal progression and you lose the opportunity for those patients, perhaps it will be better starting the liver. But, as much as we don't have like good level of evidence, it's kind of a la carte decision, and that's why multimodal approach, it's necessary for those kind of decisions. Okay, but in talking about multimodal approach, then we have like many questions to address. It's about chemotherapy. So the points when you discuss with any medical oncologist, usually we listen, well, look, chemotherapy first, it's great because usually you test the biology of the disease in the patient, you test the chemo responsiveness, and then as a surgeon, you got an extra, a bonification that you got a downstation. We are talking about resection, not about conversion therapy, okay, guys? So, so if the patient is already resectable, perhaps we have to deal with that. And those papers showed up. This is the first paper from Nordlangier. That's what showed here that you got like a sorry, no, in Portuguese, sorry. You got like a little advantage in overall in recurrence-free survival, but when this follow-up was a little bit longer, and they follow again, those paper was 2018, and again it came back with later overall survival, that with a really good follow-up, and then no difference in overall survival. So does it really matter until right now? What we do in the overall survival doesn't change. And this is, we studied later in the beginning, but this paper, since it's a meta-analysis, but I don't consider it like level 1 of evidence because we don't have only randomized clinical trials here. Those trials that are not randomized, however, they put like a strong, the worst patients in the chemotherapy. And even that way, we got like some advantage with surgery and chemo. And then for both overall survival and recurrence-free survival. However, when we look just to randomized clinical trials, no difference in overall survival. This is, we try to look at that and see what's going on. And then when we look at it, we saw that the recurrence-free survival perhaps would be a surrogate of overall survival. And I don't think that people will plan to big trials to get overall survival as an outcome for colorectal liver metastasis, especially nowadays that we are pushing their survival with good chemotherapy, also immunotherapy, and then reapatectomy. So it's really hard to get it. Perhaps the calculation should be, this must be the goal. But when this paper, it's pretty close to that one that I proposed, but with more criteria, because here it's just look for the clinical trials. What's interesting that, again, no difference in overall survival and difference in disease-free survival. This paper, what we look at here, that when we look to the disease-free survival, we got 3 studies that compare chemo and surgery alone, and then you got some advantage. So the bottom message to me that you have to offer chemotherapy. When it's complicated to know, and that's why we propose another study that I will show. So the selection, it's totally done by chemo clinical risk scores, and most of the time, even if you don't open and check it like phone score or whatever, but your mind, I guess that's common sense that you're thinking about markers of worse prognosis, but you can offer chemo sometimes. Should improve free and overall survival, but overall survival with a lot of caution about that. But it seems that we don't have yet the best time to do it. So what we have to ask you, as soon as I arrived to Memorial as lung cancer as research fellow, I was really concerned about it. Well, you know, I'm just finished my training. I saw all the time people doing, you know, this guy, this patient should go to chemotherapy first, and that should go to resection first. I said, I want to read that paper, to understand why this guy is talking about. And I could not find it. At that time, NSA BP tried to do this trial and failed because they couldn't accrue patients. And that time, I discussed with Dr. D'Angelica, and so we look back 10 years of practice in memorial slow catering and check for those patients that are initially resectable and how they were treated. Clearly, what we saw that the patients, let me see. So those patients that went to perioperative chemotherapy were clearly younger with less comorbidities. However, they have multiple lesions and shorter disease-free intervals. So if people think that were really bad, why not try to control systemic disease before? That's what they did. This paper in the beginning was so like that, you say, wow, so you have to offer adjuvant. No, but clearly we are not talking about the same patients. I just explained the selection bias. And then we split in low risk and high risk, and this difference just disappeared. That's for recurrence-free survival. And overall survival, again, doesn't really matter. You do your best, but there's no impact in changing a lot. And regarding preoperative chemotherapy, I was thinking how to explain the way to treat that. So if we can control patients and systematic disease, so let's offer them systemic control. Good. For surgeons, you have the bonification, you got some downstages and perhaps do easier surgery or smaller surgeries to help patients. And then finally, you got a lot of control later and you do the surgery. However, I have to remind you that some players here working with chemotherapy, first of all, the function of the liver must usually related to liver volume. This is an important concept because we have to think about that. And if you offer a lot of chemotherapy, perhaps the function will not be that great, as well the regeneration, okay? And one thing that happens, and when it happens, it's totally, complicated when you have like missing metastases. Sometimes the medical oncologists, especially if you are not in a center that had multimodal approach and people just refer the patient for you and say, look, I prepared the patient, I deliver like 12 cycles of chemotherapy, she's doing great, now you can remove them, and you look and say, where is the lesion anymore? So this is, you have to deal with that to understand. Because when you're thinking about the liver regeneration, you always have like the concept that, wow, it's great to have to check it. And, this is the legend of Prometheus that, he thought that was a good idea, give the fire to the mankind. And Zeus were not that happy and put him in a rock, and the eagle every day was there. So this is a legend as well. I cannot say that's a legend that that the liver will regenerate, but it's not that easy. That's not, you just cut and go in there. But, as much as the mankind doing the good use of the fire, it's a legend for me. Also, the liver regeneration should be seen cautiously. So why I'm saying that? Because you have a chemotoxicity. What is impacting bleeding and fistulas. But when you look to the papers, doesn't impact mortality. However, the morbidity impacts. And one thing that we have to deal with that's complicated, and it impacts imaging. So usually with oxaliplatin, you have like blue liver. So you have a dilation, sinusoidal dilation, and irinotecan, you usually have a really fat liver. So then what happens in the practice is that not necessarily the lesion disappears, but you cannot identify them really well later because you change the background. This is also a limitation from the methods that you are analyzing. So sometimes it seems that disappear. It's clearly related with the size of the lesion, and then also related with how long you expose those patients to chemotherapy. So if you expose more, more than 6 months, and perhaps you see like this paper from showing more than 9 months, will probably disappear a lot of lesions. So you have really small, if you offer and complete a lot of preoperative chemo, you have problems later. One thing that I guess that I heard Anna discussing about it in that section also was some marks sometimes helping patients, like those presentation. So you put the mark and the fiducial, and then you can get better, come back later. We look at that like a review. What's interesting that when you look for those many, not that much, but I mean, seems that a lot of people dealing with this problem and trying to solve it. And what's interesting, when you look to the intraoperative findings, you can't find a lot of them during the surgery again. But however, you have to have the ultrasound. It's mandatory for colorectal, I guess. Makes a lot of difference, especially if you're talking about multiple disease. But sometimes you cannot even find, but they are there. They just regrow. And so this is an option also. You do have to think about that. Why are you offering like a right sectorectomy, sometimes a trisectorectomy for a patient that's missing metastasis? Maybe you are over-treating that patient. You lose the opportunity to do more chemotherapy, maybe. And again, if you have a recurrence, how to deal with that? So one thing that I personally like, and it's that when you have the fusion with the image, like the ultrasound, either MRI or CT scan, it helps a lot to find in the intraoperative the disappeared lesions. It's kind of helping GPS for navigation. It's helping a little. I guess that's nice. Another concept that's important about liver regeneration and selection of those patients, it's you can offer a rehepatectomy with real gains. So most of those patients that have, this is the recurrence, so most of patients that you perform the hepatectomy will recur in the liver. And then if they recur in the liver and you offer again a new hepatectomy, those patients remains doing well, or at least close. So you can, that's interesting. So if you need to preserve the parenchyma, if you need to do rehepatectomy, parenchyma sparing, it's mandatory to those patients, especially if you're talking like small lesions. And to more to the residents, the way that I think to explain that. So I like this picture. I think that's, I would be impressed if I saw it personally. But what's interesting, when you have like some peripheral disease, you can just, go there and do like this, and fine, you got a good regeneration. The issue that I was talking about, the regeneration, it's especially when you have this problem, because the hepatocytes will regenerate. However, the main vessels, the main structures, you not to have like regrowing of a right portal vein, a right artery. So this is the problem. Then sometimes you do like a really big surgery. So everything you have to pay attention. And parenchyma sparing, it's, it's a long day. You good breakfast, and and you spend like a day doing like many resections for the same patient, but you kept a really good volume for those patients, and that's it. And sometimes really demanding resections. Here I cannot show you well, but this is the a sponge over the vena cava. The caudate was resected, so even looking. So you do like tunnels and everything. So that's important. And I think that you have to select patients for those goals. But we are talking like quite old school, talking about clinical risk score. But oncology has changing. Definitely more personalized medicine, it's coming more and more. But today, what do we have that really stated that patients with some markers like HAS mutations, you definitely have to pay a lot of attention about them. And also, if you, as soon as you got the marks, you saw the subtypes of patients according to their biology, which changes a lot the perspective. When you look to, for example, those patients are patients that were treated with HAS and non-RAS mutation, and you see a lot of difference. Regard if you are talking about resection, but also this is an interesting paper talking about ablation, but again, they recur more if they have HAS. So you have to pay a lot of care in how to decide about that. And then this, doing a parallel with Fong score, this game score showed up later with Hopkins, I guess. What's interesting that they do a lot of calculations, you know, but it's interesting that they do a relation about the number of the tumors and also the size of the tumors, and it creates like a tumor burden score, and each of one this counts as 1 point, and the tumor burden score you can have 1 or 2. Extrahepatic disease counts as 2. And what's interesting that when you look to the curves, so you can split a little bit better than Fong score, and that's why people are looking at that. So we are talking about loss of biology, oncogenesis. But when you look to those papers, so this is more updated. When you look to those papers and you check, like if we use together some agent to help, like bevacizumab, so we will try to impact angiogenic factors, and you don't see difference for resectable lesions. It's the same way when you look to cetuximab, you see that those patients got worse prognosis. Again, we are talking about resectable colorectal liver metastasis. We know that they have some role for conversion therapy, but for resectable, not. And when we start to look and trying to organize and everything, regarding resectable colorectal liver metastasis, I always check in firstly with the presence of the primary. If there is symptoms, so it's bleeding, obstructed, so I'm good, or either to stent, deviation, whatever. If the primary is resectable, also perhaps start for that. But if we got both asymptomatic or with primary already treated, then I have to check carefully in a multimodal approach and see if we are dealing with low risk or high risk, because this is the way that we perhaps can improve something, some survival for those patients. And regarding the low risk, I see that if the patient can tolerate the whole treatment, it means surgery and also systemic treatment. If they not, perhaps they can be tolerate the surgery yet. So we offer the surgery. The surgery remains the main treatment for colorectal liver metastasis, especially if the patient cannot tolerate the chemotherapy. But when you look to if he can, then you get to decide either starting liver first or then chemo first. You know, the literature, it's open for that. We don't have that evidence, so it's much more according to the service or the preference. However, to right risk, if easy, you know, I put that way because if you check in the literature, yes, you can, but I don't think that's a good idea. You know, I just show you that they go badly. Why you should operate it firstly? So that's my preference. It's doing like chemo first for those patients, okay? That's especially if they are gut complex. But talking about surgery, otherwise you are a surgeon, you like it, and me too. So that's here. It's the rationale that we try to build, and you know, it's a multimodal approach for sure. It's not a decision from only for the surgeon. You have to have like good radiologists, good medical oncologists, and the surgeons together thinking about that. especially radiation oncologists also, if I talk about rectum. So that's important. But to surgery, so clinical performance, it's important. I like the idea to have previous putative systemic control of the disease. And liver presentation, again, it's always complicated when you think what's the way to go, but resectable versus non-resectable, you have to judge it. And the goals that you have to have in mind, today you have some benefits if you do R1 resections. For vascular R1 resections, it's present by Paul Bruce series and anything. However, I'm uncomfortable to plan a resection if I'm going there directly to do R1 resection. You know what I mean? If it is the result of my surgery, okay, we did the best and that's it. However, going there, knowing that I will do it, perhaps not the time yet to do the surgery. Remnant volume, it's important, and minor versus major hepatectomy, how to decide. And resectable, I got like a really standard, this is descriptions for AHPBA. It's quite the old paper, but it's stated like that. When you look 2 contiguous segments in flow and outflow. So this volume, I don't believe that, with a lot of NASH, a lot of things going on in chemotherapy, probably previous chemotherapy, at least 30, I guess. But it's kind of empirical, okay? And presence of extrahepatic disease, primary tumor, and access. This is controversial. If you are doing open, lap, or robotic. Today, a great debate, a lot of propaganda, and they have to pay a lot of attention. When you open like this and people show, so this is good, you can do it. Yeah, definitely, you can do that way. Laparoscopic way, it's interesting because in the beginning, those patients would be contraindicated. So you have open colectomy, previous colostomy, and then we did like a right hepatectomy. So the things are changing. We can offering for some patients and the robotic also hepatectomies. The goal here, it's my impression, and it's not all about cosmetics at all. But the recovery, it's great. And this paper, it's really nice because it's a paper that showed up in 2016. Looking for that time, like more than 9,000 surgeries, liver hepatectomies. And then look at that. Even for the HCC, that the worst patient that you have in liver surgery, for cirrhotic patients, those are the more operated like that. So makes sense. And colorectal is the second cause. And then definitely minors going to bigger, major surgeries. And makes sense. You are beginner, you're starting. So this is a paper for Daniel Sherkin, really well-known paper, that show that you have to go like peripheral, and that's it's called, and the upper and posteriors are called non-laparoscopic segments. Oh, sorry about that, but this is the criteria that show how they classify the difficulty. So the worst would be like posteriors and caudates are worse than hepatectomy, right? Hepatectomy, exactly because the position and everything. It's a paper that's interesting because we could compare among patients how difficult could be. And this paper, it's a randomized clinical trial that show good results for right hepatectomies in colorectal. And this is interesting because when you look at that, you see that minimally invasive approach provide better outcomes for short outcomes for those patients. And as surgeons, I can tell you that you have to change your mindset. You are always looking to the surgery like that when you do open, and then you start to like different view perspective. And one thing that you change it. You are not looking that way, but you look below, and it's interesting. Instead of see that as a limitation, you take advantage of the method to do it, to make it better for you and for the patient. So this is a way. For example, in this last picture, you see the vessel just below It's interesting when you want to control, for example, a middle hepatic vein. You see that clearly below. You can dissect it. So it's interesting because you take the advantage of the method. This is right hepatectomy for colorectal liver metastases. It's, for example, this is what I'd like to show this video. It's the way that Professor Sobrani standardized to do like the caudal approach. So that's interesting because you not even mobilize the liver anymore to do it. You do the auto resection. At the end, we mobilize the liver. It's interesting because in that way, you're facing directly the parenchymal transection plane. You identify, and then you finish. What I think that's interesting because it's a way to reproduce and a way to favorize patients. And the post-operative course, it's totally different. The patients are walking in the first post-operative day. They are doing well. For sure, it helps a lot, in my opinion. And when you look at in the beginning, we are talking about synchronous and simultaneous resection. Then we start to go and see a lot of people are doing also simultaneous resection, even for laparoscopy or resection. So the limits are being pushing all the time. For example, this is a case of a lady that we did a sigmoidectomy and lateral left sectionectomy. And that's another case that was a posterior resection, non-anatomical. I will just go a little bit. Okay. And what's interesting that I will skip that. That it's interesting that time what we did both the resection of the posterior and then our colleague from colorectal did the reconstruction. What I think that was time to change that a lot of information and appeal to robotic surgery as well. So the first things that you have to state, there is no paper to stating that one will be better than the other. So we have to pay attention about that. Oncological and physiological principle must be followed regardless on the preferred access. This is, I'm surgical oncologist. I love minimally invasive surgery. However, I will always be surgical oncologist in the first place. So if you are dealing with issues with margins or you are doing bigger hepatectomies as used to be in the beginning, people are over-indicated like right hepatectomies, left hepatectomies, exactly to make it by minimally invasive instead of do like a parenchyma sparing. So this is not good in my opinion. And that's why I guess that the robo perhaps will help you because the robo sometimes improves some skills for some areas. And so you can decrease the surgery, shrink the size. And this is important in my mind to avoid bigger surgeries. I was discussing this with Professor Marco before we started, that the way that you have to find a place to do robo to do better, not to do the same as laparoscopy. Otherwise, you keep the laparoscopy, it costs less, it's more accessible. Why do you should pay for something that will not take so advanced? So that's the concept that I like it, that you can accept so areas that are not really good. So now the non-laparoscopic perhaps will become a robotic access. This is nice. And this is a paper that we work together with a really good group from EOS. And this paper will reproduce basically the same paper of Syria again, but looking now for robotics. And the numbers are increasing so much. It's just a parallel with the other. And this is nice because compare both ways. So now we are doing here and probably will increase. Well, in the beginning, what I did exactly what I just explained. I started doing just the small piece, the little things, and then come to gallbladder. But one thing that's nice, it's the approach for for posterior sectors. This is nice because here I realized that I came offering something different. So this lesion was quite big in the posterior sector. And when we start to look at that, what's interesting that you saw the lesion and the robot can help you with articulate forceps, so you can turn in one direction, the other, and you start to make it It's a good access. You don't need, for example, for laparoscopy, a lot of people would do like big posterior sectionectomy, or they would do a transthoracic approach with some trocars. And I think that with robot, you can make it better. That time it was just the harmonic scalpel, rigid one. I don't know, I cannot, you'll see if I can. I don't want to lose everything again. But this, what's interesting that I will try because I'm concerned about the time. So I finish, sorry. But this is the results, you know, you can preserve a lot. And this one, it's interesting because now we start to put like 4 lesions together. And those 4 resections, for example, here, instead of to do a lobectomy, we start to do like a really smaller resections and preserve a lot of parenchyma. You know, the patient will recur in that liver. So if you keep it, we'll keep the chance for the future for next resection, especially if you're doing a robotic approach, probably less adherence from the future as well. So that's interesting that we did it. And then this is posterior. You see the gerota, the liver is turned to the left, and now with articulate we do the resections in small piece instead of do big resections. That's why I think that robo can be better than laparoscopy. Otherwise, you can keep it. And this is. I'm sorry, my last case in Brazil was a caudate resection and a posterior in the same patient. I was so excited, but the video doesn't work, as always like. So I got this old video from a caudate because the perspective of this video was for intrahepatic lithiasis in the caudate. But what's interesting, that's what I want to show. That's why it's a lot of inflammation. It's quite juicy. But what's I want to show you here that's interesting, that the view that you have, the perspective that you have, perhaps with a robot, it's different. You see the anatomy in another perspective. I will show you the end of this video. It's a short video that you see the common trunk from middle and left hepatic vein. Below, that's different. We don't have this view when we're doing open surgery. You see that's the cava, the final aspect of the cava. And when you go up, you see there like the trunk just below. You release the Anschutz ligament and you see below. This is nice, you know, instead of become limited, you do it. So to finish, so what my way to think that we have like many scenarios, but favorable presentation, low risk patient, perhaps you can do the resection per front, but chemotherapy is mandatory. But if you have like major multiple resections, right risk recurrence, it's a good idea to start to chemo to see if you are not doing a futile, I don't know the name, you know, an unnecessary resection, maybe harming the patient. And chemo first, for sure. In the ugly, you know, if you answer resectable and everything, so I sent to Anna to do the pumps, and then you try to recover those patients later. So thank you. I'd like to invite you, all of you, for this consensus in Paris. It's the first consensus on hepatopancreatic biliary surgery. It will be great. We also have a course in Brazil for HPB. It's at IRCAD. We would be happy to have you. I guess that also we have like online. And to acknowledge, I'd like to acknowledge, say thank you to American College of Surgeons for this international guest scholarship that give me the opportunity to be here. And I'd like also say thank you to my family, because I'm here with you having a good time, but my wife is there taking care of the kids. And my family was at Boston with me. Also, I'd like to say thank you to Unifesp that's supporting me to be here. And then for sure, for University of Colorado, it's a privilege to be here. I'm so honored. And talking about University of Colorado, I don't have vocabulary, even in Portuguese, to say thank you to Professor Del Chiaro for this reception and everything. So thank you, because you don't know, but he's also my mentor for this guest scholarship. So he's helped me to arrange all my trips. So thank you so much, Professor. And then I don't have pictures with everyone, but I have good pictures that represent us. Thank you for all of you for the warm reception. I appreciate it. Thank you. Thank you. My pleasure.
Questions? Dr. Schulich.
I'm interested in your thoughts about the Fong score. You say you still use it. I mean, I would rather see one huge metastasis in the liver than, two small ones. And I think size of metastases should not play into the decision making. So that's my first question. My second one is, everything being equal, and there seems to be no survival benefit in giving most patients chemotherapy first versus doing the resection.
Mm-hmm.
But what I like about giving chemotherapy first is whether the chemotherapy is active or not. So why give a patient 6 months of chemotherapy without knowing whether that chemotherapy is active or not? If you still have the lesion in situ, you can see it shrink a little bit, and then it makes sense to give, more chemotherapy. Whereas other patients, if you've already taken out the lesion, you give 6 months of chemotherapy. You don't know whether it's an active regimen or not. So thank you so much for visiting us. Enjoyed your talks and look forward to your responses.
Thank you, Professor. It's an honor to be here, and thank you for those questions. Well, the size, I guess that it's an old concept that perhaps that time that size was more representative was with less systemic control. I guess that over years doing like for mono drug, for doublet and triplet, so it starts to have some less influence, I guess, about that. And this is disappearing. That's why perhaps the game that you start to do like the counts, to amortize a little bit the influence of this factor. And I totally agree with you that that's my personal view as well. To offering chemo first, it's good, exactly because we are already dealing with a systemic disease in the first beginning. So if you have some control, will be better if you understand that, as soon as you characterize that you got a more local than systemic disease, then it's the time to perform the surgery. However, what I'm trying to show here in those papers also was the idea that how the literature is represent this question, because it's really hard to address with certainty that this is the way to go, but it's my way of thinking, definitely.
Dr. Gleisner.
Thank you so much for the great presentation. It's a pleasure to have you here. My question is, do you limit the amount of chemo you give if you decide for chemo first? How much do you decide? And do you always how do you get the buy-in from the medical oncologist to make sure that the surgeons are part of the decision making before you, in the beginning, when they present to the medical oncologist, that they always have a surgeon involved? And is that off? Because this is a problem we see here a lot, that sometimes the surgeons are not involved in the treatment of those patients. And we think that there's a lot of patients that don't get referred to surgery that could be otherwise benefit from surgery.
Okay, thank you so much for the question. And I'm sorry that I wasn't clear enough. I didn't put anything about that, sorry. My point that you should offer like chemo, yes, but restage that patient, like repeat the image couple of months. I would say like 2 or 3 cycles to see what's going on, to see if you got some answer. However, if you want to sometimes wait like, many cycles, they will disappear. And now you got a problem because you will do like a surgery based on the previous image and perhaps a big hepatectomy, or you have to follow those patients. So it's complicated. To avoid this kind of drawback, in my opinion, 2 or 3 cycles, repeat the image, see what's going on. And perhaps I didn't address here because I wouldn't have time. Perhaps those patients will even progress during chemotherapy. It's another terrible situation, but it's more specific. I didn't address that. But that's why I'm doing. I'll repeat that, okay, in short course and see, and then decide, let's complete 6 cycles or let's go to the surgery already. It depends on the size, the locations. Thank you.
Any other question from the audience? Okay, so first of all, I actually, my first question was the one that Dr. Schulich already mentioned. I really am a strong believer in chemotherapy as a selection method for patient. You mentioned patient can progress that. Yeah, fortunately, we didn't go for surgery. You touched mostly in your talk, you focus your attention on resectable colorectal liver metastases. So which is your approach in unresectable first liver metastases? So which are your strategy to make them eventually resectable? And if you want me more precise, as you know, there is a lot of development in the last years, starting from liver transplant and so on. So I would like to have your opinion about, what is your approach for those patients?
Thank you so much. That's a great question. Would be like another presentation because it's so long, but I will try to make it short. So that's last slide that I put like the ugly. This is the ugly. So it's the ugly. If it's not resectable, for sure you have to start with chemotherapy, and then we're starting with chemotherapy. Again, you have to repeat, but usually you have some for the goal of a conversion. You have some agents that will help you, like cetuximab, bevacizumab, that can help you a little more, and also triplet chemotherapy. That's those studies that show to resectable that do not address that much. They don't address that much. But what's interesting regarding the technique, so what sometimes you have to do, it's 2-stage hepatectomy also, and ALPS I don't like that much. We were discussing before, because ALPS, you have the regeneration, but the function doesn't follow that much. Today, I guess that we are following for other directions like deprivation or venous deprivations, or that can provide you bigger remnant livers. And the transplantations, well, should be really, really, really selected patients, because they have like a huge tumor burden. However, they also not progressing a lot. Otherwise, it doesn't make sense to do the transplantation. And as much as almost all of them progress in the lung, we saw that the lung has a good prognosis, and that's the point that people say, well, it's worth because they don't have disease just in the lung. I don't know. I guess that we not find yet the right place for liver transplantation in colorectal. Not yet. That's my impression, but I don't have practice with that.
Well, I think we are over our time. Dr. Araujo, thank you really very much for choosing Colorado in your travel across the U.S. through the American College of Surgeons Fellowship. Thank you everyone for participating this morning. And we have a small gift for you. There are some gadgets of our department here.
Thank you.
So hopefully you will come back to visit us.
Yeah,
Thank you.
So. Thank you so much, guys.